Gallbladder removal is a highly common surgery, but a single miscalculation during the procedure can result in severe damage to the liver's drainage system. To manage these specific iatrogenic injuries, surgeons rely on a definitive framework introduced in 1995, the Strasberg classification. This system maps the trauma across three distinct mechanical vectors: whether the main duct maintains structural continuity, whether an isolated branch is blocked or actively leaking, and exactly how close the damage is to the biliary confluence. These geometric details dictate the surgical strategy, determining whether the injury can be managed through internal stenting or if the anatomy requires a more invasive reconstruction. To understand how the system breaks, we first look at this schematic of the pristine biliary tract. The architecture begins at the top with the right and left hepatic ducts, merging into the common hepatic duct, joining the cystic duct, and flowing down through the common bile duct. Normal physiological function depends entirely on this intact, continuous axis. Bile descends freely from the liver, down the main line, and out through the sphincter of Oddi. Structurally, the entire main biliary axis operates as a single, low-pressure pipe system designed for passive drainage. Any disruption to this flow, whether a physical breach in the duct wall or an internal blockage, forces bile into the peritoneum and triggers a cascade of complications. Strasberg type A injuries involve a localized leak from a smaller branch, while the main axis remains intact. This typically happens when a surgical clip slips off the cysted septum stump or when superficial subvesical ducts in the liver bed are damaged. 2 to 5 days post-operation, the escaping bile irritates the abdominal cavity, presenting clinically as localized or generalized biliary peritonitis, marked by abdominal pain, distension, and a low-grade fever. Moving down the main pipeline, we find type D injuries. This is a partial, lateral hole or tear in the common bile duct or common hepatic duct itself. A type D tear typically occurs during laparoscopic dissection, either from a clip mistakenly placed partially across the main duct, or from thermal energy damage from an electrocautery tool that later necroses and opens up. Both mechanisms lead to a rapid onset of bile ascites. In both cases, the primary pipeline remains structurally intact, even as bile escapes through the compromised wall. Many patients have an aberrant right sectoral duct draining directly into the common hepatic duct. A type B injury occurs when this anomalous branch is accidentally clipped shut during surgery, but not cut open. Because the vessel is sealed off, there is no bile leak. The patient is often asymptomatic initially, presenting months or even years later with localized segment atrophy or cholangitis, as that isolated part of the liver loses its ability to drain. If that same aberrant duct is transected, unclipped, and left entirely open, it becomes a type C injury. This causes a persistent, high-volume bile leak directly into the peritoneum, forming a severe bile collection or biloma. Because the primary biliary axis remains undamaged, an ERCP, the standard endoscopic imaging tool, will appear completely normal. To identify a type C injury, a physician must run a HIDA-scan, or an MRCP, to locate the isolated leaking sectoral branch that the standard imaging missed. Flawless imaging of the main biliary tree does not rule out a life-threatening isolated sectoral transection. When the main pipe completely fails, we enter the territory of type E injuries. These are major circumferential transections or severe ischemic strictures that completely disconnect the upper and lower bile ducts. Type E severity is categorized exclusively by measuring the remaining distance from the break to the biliary confluence. In type E1, the distal stump is over 2 centimeters. In E2, it shrinks below 2 centimeters. Type E3 occurs exactly at the confluence, leaving the upper roof intact. In E4, the confluence is completely destroyed, severing the right and left ducts entirely. Finally, type E5 is a combined injury, a major main duct stricture paired simultaneously with a separate cut or clip to an aberrant right sectoral duct. As the injury moves higher toward the liver, it consumes the remaining duct length necessary for a simple repair. Because they maintain main axis continuity, types A and D injuries are typically solved endoscopically. Look at the left side of this layout, displaying a type D lateral tear. A physician performs a sphincterotomy and inserts a plastic biliary stent directly through the lower sphincter and up into the main duct. This stent lowers the pressure gradient across the sphincter of Oddi. Rather than forcing its way out of the lateral hole, bile follows the new path of least resistance down the stent and into the duodenum. Deprived of outgoing fluid, the tear is allowed to close and heal on its own. Endoscopy does not sew the tissue back together. It resolves the physical holes purely by manipulating fluid dynamics. In contrast, types C and E injuries involve completely severed or missing tissue, mandating major surgical reconstruction. A surgeon cannot simply sew the two damaged ends of the bile duct back together. Pulling the shortened ducts together creates structural tension, which restricts blood flow and leads to the formation of severe scar tissue. The definitive solution is a Roux-en-Y hepatico-jejunostomy. Instead of pulling the ducts down, a loop of the proximal jejunum, part of the small intestine, is brought up. This creates a direct connection to the healthy upper duct. For high injuries like types E3 and E4, the remaining duct is too short or totally disconnected. To gain access to viable tissue, the surgeon must lower the hilar plate. The separated right and left hepatic ducts are then joined together to create a new confluence, providing a wide enough opening to finally stitch the intestinal loop into place. The Strasberg classification maps out the exact anatomical failures of the biliary tree. Successful repair relies on matching the physical intervention exactly to the geometric deficit of the injury.